So I'm going to just briefly talk about our Columbia Pain and Spine Institute. And we've been around since 2011, and we've been providing pain management and minimally invasive spinal care for population of the Gresham area and Portland area as well. Briefly about myself, I'm president of Columbia Pain and Spine Institute. I'm Dr. Maximov, for whom don't know me. And I got into the field of spinal care by going through physical medicine and rehabilitation and watching all the patients with the painful spinal pathologies who have had any surgeries and suffer from either not adequate surgeries or complications of surgeries. That led me to an interventional spine fellowship at University of Pennsylvania, where I learned a variety of different minimally invasive procedures, what we can offer to prevent patients from going through surgeries and hopefully avoiding all the complications of surgeries. We truly believe in physical modalities, physical therapy. We truly believe that body has amazing healing potential, and it will be able to heal itself if given proper tools. Today we're going to talk about chronic pain. We're going to talk about how prevalent is chronic pain in the world. We're going to talk about different types of chronic pain. We're going to talk about neuropathic nerve pain versus mechanical pain. We'll talk about briefly options of treating the pain, such as opioids and non-opioid medications. We will talk about goals for injections, and we're going to finish by talking about neuromodulation, spinal cord stimulation. And at the end, we'll have a question and answer session for you, so you can ask your questions, and we will be able to answer as many as we can. Now, talking about chronic pain. Chronic pain is it's probably the most prevalent condition in the world. It's about 1 out of 10 patients in the world, 1 out of 10 people in the world suffer from chronic pain. And if you think about, we have 7 billion of people in the world, and so 1 out of 10 is going to be 700 million of people suffer from chronic pain at any point in the whole world. So now we're going through pandemic of coronavirus, and if you think about this, that we have about 70 million cases of coronavirus, which is huge, which is significant throughout the world. But anytime in the world, 700 million people suffering from chronic pain. And so if you have chronic pain, you're not alone. You're suffering together with multiple people, unfortunately. Chronic pain is a bad condition to have because it affects you on different levels. It causes depression, it causes inability to take care of your children, inability to take care of your parents. And it's very costly for the United States and the world because of the lost productivity. People can't work with chronic pain, and they suffer. They have to have some interventions or surgeries for that. It affects more people than diabetes, heart disease, and cancer combined. And there's no surprises here. The older we get, unfortunately, the more degeneration we incur and the more pain we get. Our body is just not able to recover from it as fast as when we were kids. Just went sledding this weekend and kind of felt it myself on my body after that. So what is pain? Pain is a natural response to any type of damage. So basically any type of event happens, whether it's mechanical, compression, or chemical changes, inflammation in the body. The pain is sensed by our pain receptors, which are the very specialized nerve endings. And these pain receptors transmit pain throughout the nerves. It goes through spinal cord toward the brain, and brain finally feels the pain. So it makes people to think about what kind of damaging effect they are having, and they may Like let's say in case of touching the hot stove, they might pull the hand away from it. In terms of chronic pain is a little bit different than acute pain. Chronic pain, unfortunately, body is trying to do anything possible to get rid of it, but sometimes it's just not possible. So the chronic pain is, definition of chronic pain is a pain which lasts more than 3 months from the moment of injury. And acute pain is anything what falls below the 3 months. There are two different types of chronic pain we're talking about here. First type of pain is mechanical pain, and mechanical pain is, if you think about this, it's like a pain coming from the musculoskeletal system, from the muscles, from the bones, from the joints. It's also referred as a nociceptive pain in the medical community. And it main characteristic that it occurs intermittently. It depends on activity. So people, when they stand, they have a lot more pain in their knees compared to when they sit and they don't load up their knees. And this pain generally stops when people just laying down flat and sleeping at night, for example. Pain is intermittent, kind of comes and goes, and people can generally find a position which is the most relieving for their painful condition. Second type of pain is nociceptive pain, neuropathic pain. And neuropathic pain is more like a nerve-related pain. If you think about this pain, it's continuous. It may be fluctuating in intensity, but it's always there at some degree. Like sciatica pain, going down the leg all the time, and it may be better at nighttime, but it's still there. Or peripheral neuropathy pain is a typical example of neuropathic pain, where you just can't escape it. It's just always there, constant, 24 hours a day. So if you think about your pain, you might ask yourself a question: how does your pain fall into this classification? Is it constant, intermittent? What is your primary pain area, and how long have you had this pain? The other option is if you had any surgery related to this pain, and how did your pain do how did your pain do after the surgery? Did it get better? Did it get worse? And if you're having a lot of activity, what you like to do, what kind of pain you can have at the end of the day? Is it going to be much worse, or it's going to be okay? So common pain conditions, what we're going to talk about here is the very common conditions are sciatica, which is basically impingement of the nerve inside the spine by a disc or by a cyst or by a joint. And it's called radiculopathy in the medical terms, and it depends on which nerve root is affected in your back. This pain is going to radiate in a very certain pattern. So when I'm asking patients during the examination, okay, so how does this pain travel down your leg? How does this pain travel down your thigh? Is it in the front? Is it more on the side? Is it more on the back? That's all makes sense for me, because I'm trying to kind of connect the dots together and figure out where is the problem in your spine. The other common condition is peripheral neuropathies. Can be coming from, we're going to talk about peripheral neuropathies, what can cause peripheral neuropathies. CRPS and causalgia, it's a kind of crazy condition when any type of nerve damage, whether direct or indirect nerve damage, can lead to the activation of sympathetic system and then make your hand or leg or foot swell and lose nails, lose hair. It's a very bad condition to have. Can't control it at all, completely. 100% typical neuropathic pain. Phantom limbs post-amputation syndrome is very well known. Post-herpetic neuralgia, trigeminal neuralgia. This is very common pain condition which are associated with activation of the nervous system and the pain coming from the damaged nerve. any type of surgeries, as you know, the most common is post-laminectomy syndrome or failed back surgery syndrome. It's so common. It's just, we deal with it all the time here in our clinic, unfortunately. And interesting statistics about this post-laminectomy syndrome. So after first laminectomy or first spinal surgery, the chances that you're going to get better is better than 50%. It's probably about maybe 60%. But if you have it second time, the chances fall down to 30%. And if you, God forbid, go to the same surgeon, is going to say, hey, listen, second time didn't work, third time is going to be a charm. It will not, because it's only 15% chance that you're going to get better with this. And if you, God forbid, go for the fourth one, it's only 5%. So the more surgeries, not necessarily better. Pain can come after a hernia operation. It's a very well-known condition called neuralgia, and hip knee surgeries are very well known to produce neuropathic pain as well, because a lot of nerves going around the hip joint or knee joint. And post-amputation pain is, again, very well known. So low back pain. The most common reason for low back pain is a normal degenerative process. So if you think about this, that every time we wake up in the morning and we go to bed at nighttime, we go to bed a little bit shorter than we were in the morning, by about maybe half an inch. And it's just gravity, normal gravity force does it to our body. And so this kind of gravity, normal accordion push and stretch effect creates degeneration in our body and our discs. Discs are losing water content once we age, and it creates increased loading on facet joints, on little joints on the back of the spine, which kind of holds vertebral bodies together. Ligaments become thicker, and a combination of this disc bulge from the back and ligaments pushing inside the spinal canal, and facet joints become bigger and start pushing inside the spinal canal, can create a condition called spinal stenosis, basically narrowing of the spinal canal, where all of this above mentioned factors create very tight spot where the nerves go through, and it might impinge the nerves and create a lot of back pain, can create a lot of legs pain. People just can't go upright, walk upright, and they tend to lean on a shopping cart in a store or in a walker if they can. It alleviates the pain by opening up spinal canal. Facet joint pain is also very well known. It's just pain which is worse when you stand and better when you sit. And also degeneration creates loss of calcium inside our bones, and our spinal bones become weaker and softer, and it might even fracture. You create vertebral fracture, which can be very painful in acute phase and chronic as well. Sciatica pain is basically pain, numbness, or weakness, which is associated with one of the nerves being impinged in the back. Very common condition. People suffer from it all the time. Pain usually comes from the buttock, radiates down back of the thigh, and kind of goes down back of the leg and all the way to the foot. And the majority of the symptoms results from impingement of the lower lumbar spine nerve roots from L4, L5, and S1. That's the major nerve roots, which kind of comprise sciatic nerve, which goes down back of the thigh, back of the leg. It results in muscle weakness in a certain groups. So during a physical examination, again, after we ask very thoroughly of how does your pain go down the leg, we try to figure out which muscles are affected as well. So if we feel that you describe in its L5 nerve root, so side of the thigh, side of the calf wraps around to the top of the foot, and we feel that you're just basically bringing the ankle up, is weak motion. It might lead us to think that L5 nerve root is impinged, for example. Very, very commonly caused by disc bulges, or once we age, it caused by condition called foraminal stenosis. Again, it's enlargement of the joints and ligaments, which compress the nerve and create this kind of nerve weakness and loss of nerve fibers. Another common condition is persistent knee pain. Same process as with back. Unfortunately, knee is a major weight-bearing joint, and it goes through quite a bit of motions throughout our life. We walk all the time. We use these knee joints, and we tear meniscus, we tear ligaments slowly and gradually. This loss of meniscus, which is kind of internal lining and the cushion in between of cartilages, it can lead to cartilage to approximate to each other and start rubbing on each other. Cartilage of the femur start rubbing on the tibial cartilage and create some erosions inside the cartilage, which gradually lead to even bone-on-bone arthritis. We all kind of hear this all the time, that people say, "Oh, I have a bone-on-bone," and sometimes we look at the X-ray and it's really kind of looks like it is bone-on-bone, no space left in the joint. The usual recommendation is to start with improving muscle strength, because it helps to brace the knee joint and align the knee joint and protect the knee joint. We also use steroid injections for knee pain to calm down inflammation when the pain is very severe. Viscous supplementation is another option, basically very fancy word for we use a very thick viscous substance to inject inside the knees to provide cushion to help the knee joints and cartilage not to rub on each other that much. We can, in advanced cases, we can even burn little tiny nerves which supply knee joints, and it will alleviate the pain. And sometimes we do even platelet-rich plasma. It's a neuro treatment of blood, your own blood. We draw it from the vein, spin it in the centrifuge, inject it inside the knee, and it stimulates normal regenerative potential. Knee replacement is always an option in case of very resistant to treatment knee pain. Peripheral neuropathies is a very common condition. Any type of toxins can create peripheral neuropathy, alcohol is one of the major toxins creating peripheral neuropathy. Diabetes is a bad condition to have because it basically crystals of the blood sugar which floats through your body damages lining of tiny blood vessels which supply very, very tiny nerves, and this tiny nerves just die out and create this very painful condition called diabetic peripheral neuropathy, which is burning, searing pain in feet, and sometimes it even progresses toward the upper legs and maybe even go to the fingers and hands. There's so many peripheral neuropathies. I mean, peripheral neuropathies can be inherited as well. Some people are just born with it. Some people are just not lucky to have this genetic setup they were born into. And we have a treatment for that, which we'll discuss later. So this is treatment for persistent nerve pain. Of course, we're going to start with the minimally invasive treatments first. We'll always think about behavioral therapy, meditation, trying some biofeedback, try some physical therapy, massage, acupuncture, NSAIDs, non-steroidal anti-inflammatory medication, TENS unit. It's called transcutaneous electrical stimulation, basically. And after we do that, we progress to second tier of treatment, which include low dose of prescription pain medications and some of the injections, including nerve blocks. And we go forward to the third tier in case of lack of success, and that's where spinal cord stimulation and neuromodulation comes to play. Briefly, I want to talk about opioids. Of course, we all know that opioid epidemics is real in the United States, and the risks of opioids are real. But opioids are, unfortunately, it's a measure of last resort for people who tried and failed every single possible non-opioid medications, and they just looking for alleviation of their objective painful condition, and opioids can provide it. They improve some function in nociceptive pain like osteoarthritis, Neuropathic pain, not so much. They just don't tend to help with the nerve pain, and don't tend to provide this relief for neuropathic pain. And obviously, tolerance is a main side effect of opioid usage, and the tolerance leads to increase in dose and sometimes possible overdose and addiction. Constipation and nausea is very often, and somnolence, sedation are very common side effects of opioid medications. So we try to use them sparingly. We try to use some other better modalities. So neuropathic pain medications such as Lyrica, gabapentin, or Neurontin, and antidepressant medications such as Pamelor or nortriptyline, amitriptyline, they're good medications. They help with neuropathic pain a lot better than opioid medications, but unfortunately they have some side effects. And like with Lyrica or gabapentin, a lot of patients complain of weight gain, sedation. Sometimes they can just get vivid hallucinations. In one patient, I even had a hair loss with these medications. It's again, hair loss is extremely rare, but I guess it can happen. If we feel that medications create more side effects than they help, we move forward with the next options. Next option is going to be, we're going to talk about some injections, some common injections, what we use here. For disc herniation and radiculopathies, for sciatica pain, we use epidural steroid injections, very helpful to calm down inflammation around the nerve and very helpful to release the pressure from the nerve created by swelling, which is caused by inflammation. If pain comes from the joints in the spine, we identify which joints are responsible for this by doing diagnostic injection. Diagnostic injections are injections when we actually use just lidocaine. We don't use steroid. We just put numbing medication like lidocaine or novocaine to anesthetize the joint we think responsible for the pain. And if we have a good pain relief, if a patient reports good pain relief, more than 80% of pain relief after these injections, we know which joint is causing this pain. So in this case, we can treat it. We can treat it with steroid injection inside facet joint, or we can treat it with a nerve burning, radiofrequency ablation. Nerve burning has been shown to be very successful of treatment of degenerative joint problems in the back, and nerve burning is done basically through the needles, 3 needles going on one side, 3 on the other side, and we anesthetize the nerve. We put a little tiny wire through the needles and connect this wire to the device, flip the switch, and in about 90 seconds, it burns the nerves on one side and 90 seconds on the other side. People go home the same day. Procedure takes about maybe 10 minutes from start to finish. Very useful for axial, meaning like without radiation toward the legs, back pain. Very helpful for about 6 to 12 months. Then nerves tend to grow back, and we just can redo this nerve burning procedure again if necessary. Again, diagnostic injection, we're pinpointing where it's pain coming from. We're using just lidocaine. Therapeutic injections, we go ahead and treat it with either steroids, or we do epidural injection, or we do nerve burning. Role of spine surgeries, absolutely, yes. Even though we're going to do everything in our power to prevent you from having surgery if it's possible. If it's not, or you have bad signs like a weakness, progressive weakness in the leg, foot drop, like if you're losing balance, or if bowel or bladder incontinence come because of the severe compression created by, let's say, disc herniation or spinal stenosis. In this case, if injections are not an option, or there is a failure of injections, we can send you to a spine surgeon, and the spine surgeon will be able to help you by decompressing, by mechanically opening up the spine, or stabilizing spine if it's unstable, and helping you in the long term with this. Sometimes we see these conditions where we would like patients to have operation, but patients just cannot go through operation, whether because they have different health conditions like COPD, like uncontrollable, like blood clots, or cardiac conditions where they just cannot go through general anesthesia. In this case, what do we do in this case? And what do we do if we try everything, injections, if we try medications, and there's just nothing working, nothing gives pain relief, and injections give only maybe 1, 2 week, 3 week, 4 week stops pain relief, what then comes back. We cannot do injections forever. And we have a great modality to help us with this resistant to treatment conditions. Now we're going to talk about neuromodulation. What is neuromodulation? It's an alternative, non-opioid alternative to a variety of nerve painful conditions. Very important for us to understand that this neuromodulation helps the best for neuropathic pain, nerve-related pain, rather than nociceptive pain, joint or bones or muscles-related pain. It's well established. It's been around for a long time. I've met one of the pioneers of spinal cord stimulation, neuromodulation, who used to use Radio Shack wires back in the late 60s, putting in the patient's back. I didn't want to hear about that, but that was interesting. So it's therapy which uses electrical stimulation to block painful impulses from traveling through spinal cord and reaching to your brain. It pretty much uses the same technology as a pacemaker for helping cardiac rhythm to be regular. It offers also offers a trial option where people can go ahead and do the trial first before they sign up for a permanent spinal cord implantation. I think this is great because if let's say for spinal surgery, if you could have a trial of spinal surgery and kind of feel how you're gonna be after spinal surgery, people are gonna be a lot more comfortable if, let's say, going through spinal surgery. So this modality gives this trial option. How does it work? So it works through the wire, which conducts electrical impulses toward the spinal cord, and it prevents painful impulses traveling through spinal cord. It prevents them from going through spinal cord and connecting to the brain. So basically kind of stops them. And instead of pain, people feel either pleasant tingling or they feel nothing. There are two different modalities. So how does it work? How do we do trial? Trial we do through the needle. It's similar to our epidural injections. We put needles in toward inside the spine. We slide little tiny wires called leads inside the spine, and they are not attached to anything. They're just gonna freely live in a separate compartment from spinal cord. Then we take out the needles and we're gonna connect the wires to the battery pack, attach wires to the skin, put a big band-aid on your back, and we're gonna have you to walk around and test drive it for about 5 to 7 days. And you will be the one to judge if this modality works for you, if it's gonna be alleviating your pain while you're doing things you like. And we don't want you to stay inactive. We want you to actually actively test drive it and see if it works for you. If trial is successful, we move forward to the permanent treatment, permanent stimulator placement. Our goals during the trial, we're looking for a few things. We're looking for first pain relief. Of course, we wanted to have pain to be less than before the trial. And we're actually looking for about 50 to 80% of pain relief during the trial. Second thing, we're looking for increase in functional status. So if you are able to do something what you weren't able to do before, or you can walk for a longer distance or longer time, or do activities what was hard for you to do before a trial, this is the best, I think, outcome of the trial. If you're able to reduce pain medication, it's great. It just shows that you have less pain, you have less need for pain medications, and it shows that the trial was a successful procedure. And so if trial is successful and we do permanent placement of the stimulator, it provides a much longer lasting solution and a much less complication-prone solution compared to opioid medications, compared to nerve medications, compared to antidepressant medications, any type of medications, any type of chemicals, what you put in your body has a propensity of giving complications every time you do this. This has no chemicals released in your body, it's just plain electrical solution. And you'll be confident to know that you're going to feel great after a permanent placement because you had a trial and you had this kind of preview of how's it going to work for you. Best candidates for neuromodulation, again, people with nerve pain, and nerve pain should usually last for longer than 6 months. You don't want to have some permanent device placed in you and then pain goes away in a week or so. So you want to make sure that this condition is chronic. Pain is persistent and escapable, the same continues, fluctuates with intensity. And if surgery is not an option and you tried everything possible, I think that neuromodulation is a great option. Again, all of these conditions we talked about, which are more neuropathic compared to nociceptive, compared to mechanical, any type of nerve damage condition, whether it's from surgery or from peripheral neuropathy or from post-herpetic neuralgia, or even sometimes multiple sclerosis can be it can be used with that, or CRPS. All of these conditions are ideal for spinal modulation. So let's talk about evolution of this neuromodulation. Again, from Radio Shack wires, we'll move to technology which allows to be upgradable. So if there is any new development come on with the generator of these impulses, we can upgrade wirelessly if you have permanent stimulator placed with upgradable battery. It does not require a lot of manipulation from patient, usually set and forget technology. The recent development that it's full body MRI compatible, which is great, absolutely great for patients who need MRI in the future or who need frequent follow-ups with MRI, like some sort of cancer condition. And the technology is always improving, and recently the technology improved again by providing burst stimulation. Burst stimulation is basically different stimulation from continuous stimulation. It allows our body not to get used to continuous stimulation, which was produced by older spinal cord stimulator systems. And a lot of patients with older spinal cord stimulation systems, just because of this continuous stimulation, get used to it, and it becomes not as effective. With burst stimulation allows body to take a break from the stimulation, and then this little bit of frequency, which is not even perceivable by our brain, gives again adequate response, adequate pain relief for patients, and it has much less tolerance compared to the older technology. Clinical evidence is there. It's been studied in multiple countries, in multiple continents, multiple studies in the United States and outside. More than 20 studies were presented, and the outcomes show that there is a superiority of this newer burst stimulation compared to the older continuous stimulation technology. With burst stimulation, patients usually don't feel anything. They just don't feel their chronic pain. With the older technology, this chronic pain was masked by a pleasant tingling sensation, kind of constant low-level buzzing. And people like to have no feeling rather than having the constant buzzing in their bed. So a lot of patients, again, prefer newer technology compared to the older technology. So now we have a common questions about stimulator. Will it cure my pain? It will mask your pain, but it will not cure the source of the pain. Again, the stimulator is basically a cover for the pain. It allows you to escape this pain if condition which is causing this pain is incurable. Will I be able to reduce my pain medication? If you will be able to reduce your pain medications, it's fantastic. There's no requirement for a reduction of pain medication management, pain medications, but if spinal cord stimulator is going to alleviate your pain, you're just not going to need pain medications. I've seen patients getting off pain medications completely after spinal cord stimulation. What are some of the restrictions I may have with implanted system? The majority of restrictions come in the first maybe a week or two after placement, because the wire is still, it's not attached to anything, kind of hangs in the back, and we don't want you to have any type of infection in a battery pocket. So just take it easy during the first couple of weeks, but then you may not have any restrictions. We want you to be as active as possible. We actually want you to go and do sports and go and do all of what you like to do and you cannot do because of chronic pain. How long is the typical wait once the trial is completed to receive permanent stimulator? Usually depends on insurance, but an average about maybe 30 days. And the other question, what is important is how many patients, like let's say that if we do trial for 10 patients, how many patients decide to go for a permanent stimulator? How many patients will like to have permanent stimulator after the trial? And in my opinion, in my experience in the scientific literature, is about close to 70–80% of patients who would like to have this permanent system implanted after the trial. 20% just don't like it, or it doesn't cover their pain. So in closing thoughts, in order to help us to treat you, it would be great for you to understand what's the nature of your pain. Is it mechanical versus neuropathic? Even though we're doctors, even though we're supposed to figure it out, you know your body more than we do. And if you help us to come up with a conclusion, whether it's coming from the joints or whether it's coming from the nerve, we would appreciate it. Do not lose hope, even if you have mechanical pain, do not lose hope. We're constantly working for different solutions, neuro solutions to treat conditions. And think about if you tried everything else, the simple test drive trial might just give you this option of having pain-free or reduced pain life. We care and we would like to provide the best treatment options available. We will be able to recommend it to you when you come to our appointments, when we examine, talk to you, we decide the best option for you. We're never going to move with the most invasive option available. We're always going to try least invasive and the safest option possible to try to prevent you from having pain and try to prevent you from getting into invasive surgery. That's our goal in our clinic. And I guess this is the end of our presentation. I would like to thank you all for participating in that in this evening hour. And I hope that our presentation was informative for you. And this is going to be our first presentation in the cycle. We hope to present more topics about different sources of pain, different areas of pain, like knee pain, hip pain. What can we do specifically about that?